Now let us move on to the assessment of diabetic heart disease. The risk factors of diabetic heart disease should be screened at every clinic visit. High-risk patients should receive exercise treadmill assessment or coronary angiography. A complete blood lipid test should be performed for all adults above 20 years of age. For children over 2 years of age with family history of hyperlipidemia or premature coronary artery disease should also receive complete blood tests for lipid profile. Also, another important index called the atherosclerotic cardiovascular disease risk should be calculated. This is a calculator including age, gender, ethnicity, total cholesterol, high-density lipoprotein cholesterol, systolic blood pressure, diabetes, and smoking. And this index should be calculated every 4 to 6 years in diabetic adults over 20 years of age. So what is the adequate level of lipid lowering for patients with type 2 diabetes? Plasma lipids should be lowered in all patients with type 2 diabetes to prevent atherosclerotic heart disease. 4 groups of patients will benefit from lipid lowering, as shown in the green boxes on the left, including patients with clinical atherosclerotic cardiovascular disease, patients with low-density lipoprotein cholesterol above 190 milligrams per deciliter, patients with coexisting diabetes mellitus, or atherosclerotic cardiovascular disease risk score above 7.5%. And the level of lipid lowering is shown on the right. In patients with diabetes and coexisting coronary artery disease or chronic kidney disease, the LDL level should be lowered below 70 milligrams per deciliter. In patients with only diabetes, the LDL level should be lowered to 100 milligrams per deciliter. The level of LDL cholesterol lowering depends on the intensity of statin therapy. So for patients with diabetes and coexisting cardiovascular disease, we should use high-intensity statin with the goal of LDL lowering more than 50%. These include atorvastatin 40 to 80 milligrams per day or rosuvastatin 20 to 40 milligrams per day. In patients with only diabetes or other risk factors, we should use moderate intensity statin, such as simvastatin, pravastatin, and other moderate intensity statin to lower LDL cholesterol to less than 30 to 50%. Now let's move on to the assessment of the diabetic foot. The foot ulceration is a common complication in type 2 diabetes, and it can lead to morbidity and amputation. Risk factors for diabetic foot disease should be assessed at every clinic visit. Okay, so there are some risk factors that are known to increase the risk of death in the patients with diabetic foot disease, including a low ankle bronchial index, coexisting foot ulcer, smoking, or estimated poor kidney function as measured by the estimated glomerular filtration rate. Okay, there are several stages of diabetic foot disease, and most importantly, the foot ulcers can precede the development of gangrene. Also, the severity of the patient's foot should be assessed at every clinic visit, and osteomyelitis need to be excluded. There are 5 stages of diabetic foot disease according to the Wagner classification. So the classification grade 1 to 2 are shallow and deeper ulcers involving the skin and the subcutaneous tissue. But importantly, at Wagner stage 3 and above, the infection may reach to bone and to gangrene, which require antibiotic therapy and may lead to amputation. So the neuropathic foot ulcer requires treatment to restore arterial inflow and to remove pressure from the ulcer site. Intravenous antibiotic therapy is necessary for infected ulcers or bone infection, and fibrous tissue should be debrided to prevent further infection. So there are many ways to care for a diabetic foot. First, all patients should be told to inspect their feet for sores and open infections. And the patients should carefully trim their toenails to prevent the ulceration formation around their toenails. Patients should wear good fitting shoes and dry, clean socks to prevent foot fungal infection. Finally, let's talk about the glycemic target to control diabetic complications. Several randomized control trials have shown that the beneficial effects of glycemic control on small vessel disease, such as the United Kingdom prospective diabetes studies, which show that glycemic control improves microvascular disease and their complications, and also showed a non-significant trend towards improvement in large vessel disease. The Kumamoto study in Japan also showed that intensive glycemic control can reduce microvascular complications in diabetes. However, whether glycemic control can improve microvascular events remain controversial, such as a core study in the United States has shown that intensive glycemic control increased the risk of mortality by 22%, possibly due to increased risk of hypoglycemia and complications. Also, the Veteran Affairs Diabetes Trial and the ADVANCE study also shown that intensive glycemic control increased higher mortality in patients with coexisting heart disease. Therefore, since intensive glucose control may not uniformly improve survival in all diabetic patients, individualized glycemic targets should be established. And currently, we recommend following the American Diabetic Association guideline, reaching a premeal plasma glucose level below 130 milligrams per deciliter, or postprandial plasma glucose level below 180 milligrams per deciliter, or plasma hemoglobin A1C below 7%. So in summary, type 2 diabetes mellitus is associated with numerous microvascular and macrovascular complications. And screening for these complications should occur at the diagnosis of diabetes and every year thereafter. And large vessel complications should be assessed according to risk factors and treated to prevent the morbidity associated with coronary heart disease. Okay, so this is a brief summary of the common complications seen in type 2 diabetes mellitus and their screening and treatment methodology. I hope you have learned from this presentation and to treat your patients not only the glucose levels, but also to treat their associated complications in diabetes. Thank you very much.